you, everyone. Again, Dr. Palumbo with the Adult Reconstruction Team at the Florida Orthopaedic Institute. All right, so again, my topic is partial knee arthroplasty. Trying to gear this towards the primary care physician is a topic near and dear to my heart. These are my relevant disclosures. So the objectives of the talk are to discuss knee arthritis clinically and radiographically, define what unicompartmental knee arthroplasty is and its role in reconstruction, talk a little bit about indications and patient selection, which is really the bulk of this talk. I think with partial knee arthroplasty, probably the most important aspect of achieving good outcomes is really patient selection, and then talk a little bit about outcome and survivorship. So of course, as you probably know, knee arthritis or osteoarthritis is that wear and tear type of arthritis of the knee joint. It really is a rather complex biochemical and mechanical process in which you get degradation of the hyaline cartilage throughout the knee. I will talk mostly about a varus knee, so just for simplicity, but in the varus knee, typically this will begin anterior medially. It progresses posteriorly with time and as the wear progresses until you get involvement of the intercondylar notch and development of notch osteophytes. Along with a pro-inflammatory state, you get a milieu for chemical and mechanical ACL degradation. Once you get ACL or the ACL becomes insufficient, you get progression of arthritis to the contralateral compartment and subsequent tricompartmental arthritis. And we're trying to capture those knees with regards to patient selection before they progress to tricompartmental arthritis. So here on the left, you'll see you have a normal knee, healthy joint space, typically about 6 millimeters of joint space in the medial and lateral compartments. And on the right, you have an osteoarthritic knee with tricompartmental arthritis. You have bone-on-bone wear pattern medially and subtle subluxation of the femur on the tibia with progression of lateral compartment disease. So again, this is really what we're trying to capture is before they progress to tricompartmental arthritis with degradation of the ACL. You have isolated medial compartment disease in this case and preserved lateral compartment. Cases where you have severe femoral or tibial bone loss with severe deformities, these are obviously not cases where you can consider a partial knee. Total knee arthroplasty continues to be the gold standard for knee arthritis, even in the case of isolated medial or lateral tibial femoral disease. I think the challenge with total knee arthroplasty and what we've learned over the last decade or so is that our patients are achieving higher degrees of performance into the elder years, and their demand is really increasing. And this was really outlined by Phil Noble, but outcomes and satisfaction rates with total knee arthroplasty are somewhat limited, at least they have been over the past few decades. And he wrote this paper in 2006, evaluated over 250 total knees and found that about 15% of patients were dissatisfied. And I think that has a lot to do with surgical technique and experience. This is a heterogeneous patient data set, but it's important to understand with total knees we're somewhat limited, and that's why you're seeing this rise in things like robotics and custom implants and navigation to try to accommodate for that. Partial knee arthroplasty is really another option to probably maintain a more natural feel or proprioception to the knee and have a better outcome overall. It's really defined as the isolated medial or lateral tibiofemoral resurfacing, or also would be considered a patellofemoral resurfacing, but we're not going to discuss that today. Certain benefits are improved function over total knee arthroplasty, decreased rehab time and recovery time versus total knees. Cruciate preservation will maintain a more natural knee kinematic pattern and proprioception for the patient. And of course, this is a bone-preserving procedure relative to a total knee. Here's an illustration on the right. You'll see that this is a partial knee. It's a medial compartment arthroplasty. The patellofemoral and lateral compartments are preserved. And on the left, you'll note the total knee, which in all three compartments are resurfaced. And also, it's very important to note that the ACL is preserved with the partial knee, which is really paramount in this type of surgery. So if it's so good, then why shouldn't everyone get a partial knee? Because there really are some limitations, and again, we're going to get into that with regards to indications and patient selection. In my practice, what I've found is I have kind of a dichotomy. I have one set of patients that will come in, they know I do partial knees, they want a partial knee, they want their perfect outcome, quick recovery, and they don't want to hear about the downside to it. And then I have another patient subset who just, has read about partial knees. They, read what's on the internet, some bad experiences, and they just don't. I mention it, and they just want to slap me. And those are not those are certain patients that you may not even want to consider doing it anyway on. The truth is really in the middle, and it involves a shared decision making with the patient. On one hand, you have this possibility for early failure and a secondary surgery, and this issue of persistent pain, which is somewhat complex and controversial, but it's certainly an issue. And then on the other hand, you have, as the things that we've mentioned, the benefits: improved function, proprioception. It's a bone-preserving procedure, lower perioperative risk of complications, and faster recovery. I always tell the patients the stars have to align in order for this patient to be the right procedure for you. It has to be the right knee, the right patient, and the right surgeon. The surgeon experience is critical with this type of procedure because technically it's harder to nail this than it is a total knee. And total knee has a little bit of a fudge factor to it. This does not. Again, indications by far the most important factor to achieve good outcomes with this type of procedure. We'll discuss those now. So the Cozen and Scott criteria initially published in 1989, subsequently modified. I had the opportunity to work with Dr. Scott in fellowship. Just to talk about a few of the indications. So isolated medial or lateral compartment arthritis, as you can see here with a varus and valgus knee pattern. Weight less than 82 kilograms or 180 pounds. Arc of motion greater than 90 degrees with less than 5 degrees of contracture, and angular deformity less than 15 degrees, which is passively correctable. So a case like you see on the right with severe varus deformity and probably instability noted on X-ray. These are cases that you just can't do a partial knee on, and they're not candidates, and you shouldn't consider it. Patellofemoral arthritis, we'll discuss a little bit more about this in the future slides, but just know that it's for the most part a contraindication. I would say a relative contraindication, but certainly needs to be considered. And then inflammatory arthritis or things like rheumatoid, psoriatic, those are concerns, and those are contraindications to a partial knee. When you evaluate a lot of these indications, I think you'll find that these indications really are pointing towards not overstressing the implants. These implants are not as robust as total knee arthroplasty components. Specifically, the tibia. This is the weak link of the surgery. When you look at a total knee arthroplasty tibia, for instance, you'll note that there's a large surface area for fixation. It's covering the entire tibia. You generally have large keels, sometimes even stems. You can modify the implant to have stems to improve fixation in the large patient. With partial knees, you're much more limited. It's about 1/3 the surface area. You have generally just usually a few small pegs and maybe a small keel for fixation. So the ability for these implants to stay fixed in certain quality of bone with certain patient types, like large patients, it's not as good, and it's subject to early failure. And that's why indications are so important. That's why those indications are kind of gearing you towards a specific patient subset. To talk about the subsets, young patient, really an important one. Originally, this was a contraindication in the Cozen and Scott criteria, but that really creates a conundrum because this is, again, as we mentioned earlier, this is a procedure in which it's bone preserving, it's improved function and proprioception relative to a total. These patients, if they have a partial knee, their ability to return to discretionary activities like jogging, cycling, golfing is going to be greater. So ideally, that would be the perfect candidate, the young patient. But unfortunately, this possibility for early revision is very real and pronounced in the literature. When you look at Swedish registry data, total knee arthroplasty and partial knee arthroplasty survivorship, you'll note here with total knees, this is 2009 data, but in the beige area, the total knee survivorship in patients under the age of 55 at 10 years is approaching 8%. Pretty good survivorship in the young patient cohort. Unfortunately, when you look at That same beige area, which represents the younger patient at 10 years, the chance for revision is approximately 25%. And it's important to note that this type of data set is a heterogeneous group of surgeons and patients, so there are surgeons with varying level of expertise. You can have general orthopedic surgeons. They're not all arthroplasty surgeons. They may not be high-volume partial knee surgeons, but the important point here is to note that for all comers, generally speaking, partial knees in younger patients don't last as long. Now, this was, again, my mentor, Dr. Scott. We evaluated his data and presented it in the Academy in 2014. And you'll note at 25 years, we achieved 75% survivorship, which is really rather good. And these are patients under the age of 56. So I think this kind of points to the fact that with good technique, meticulous technique, and experienced surgeon, you can achieve excellent outcomes in survivorship, even in young patients. So it's a bit of a dichotomy there. But the heavy patient, so again, we're talking about overloading or overwhelming that implant, so keep in mind that concept. But obviously these patients are going to present earlier in life just because they're loading their joints more. And then of course when you implant a component such as an arthroplasty, or in this case a partial knee, there's going to be a propensity for early implant loosening and polyethylene wear, so you have to be concerned. There are many reports in the literature, both supporting partial knees in the obese population, BMI greater than 40, and refuting it. So in my synthesis of the literature, the way at least I kind of perceive things, is that the obese and inactive patient probably can achieve good survivorship, and then the obese and active I get more concerned about. But again, that's my kind of synthesis of the literature. You have literature both supporting and refuting this concept. I think with the mesomorphic male or the large muscular guy, these are the patients I do become rather concerned about. These are weightlifters, joggers, runners, very active individuals, putting a large load and a large demand on the implants. For the most part, don't offer these patients partial knees for that reason. I'm concerned about early loosening and failure. Or at least they have to have the expectation and understanding that these implants would possibly fail early. So ACL deficiency is an important point. Again, it has to be the right knee. For all intents and purposes, an ACL deficient knee is a contraindication to a partial knee. It's important to understand this concept that with ACL deficiency or insufficiency, you get posterior translation of the femoral condyle onto the tibia. In the case of a native knee, this is going to cause a posterior wear pattern relative to the anterior medial wear pattern we discussed earlier. So it does present a little bit differently radiographically. After a partial knee arthroplasty, this is going to result in posterior translation of the femoral component, and that's going to result in loading of the implant in a rocking horse phenomenon. The implant can potentially loosen early in these cases. It's important to understand that these are not good candidates for a partial knee arthroplasty. There is substantial evidence supporting this concept of partial knee arthroplasty and concomitant ACL reconstruction. This is Weston and Simons, and published excellent satisfaction and survivorship in 52 simultaneous ACL UK reconstructions. This is definitely an option. This is a fluoroscopic analysis published by Pandit and colleagues evaluating partial knee arthroplasty with concomitant ACL reconstruction. I think the important point here is that it returned the knee kinematics to simulate the native knee with a partial knee and ACL reconstruction. So it's really rather impressive that with these types of procedures you can restore the native knee kinematics fairly well. Patellofemoral arthritis. So if you see this in the clinic, is the patient a candidate for partial knee? I would say in most cases, if it's advanced radiographically, it's probably a contraindication. There is literature support that you can potentially ignore this. My experience, and probably most surgeons would suggest that if you have either moderate or worse patellofemoral arthritis, that these patients are not candidates for partial knee arthroplasty. Just to briefly discuss this concept of dual compartment medial patellofemoral joint arthroplasty, there are several implants in the market. In my view, these are rarely indicated. I published on one of these implants in 2011. It was fraught with really poor clinical results and even catastrophic failure in several cases. And in my hands, this is just not even a consideration. So just to touch on implant pearls and some technical pearls briefly, I think the point regarding implants, this is a significant factor. There are probably a multitude of different geometries and implants in the market. There are really only several tried and true implants with long-term track records. Some of the work we did years ago evaluated geometries of specific base plates and found that certain base plates had higher intrinsic stress and micromotion than others, and these directly were associated with good or poor clinical outcomes, specifically in the registry data. So implant design is really rather important and shouldn't be ignored, and shouldn't be just using any implant on the market. Brief technical pearls, I think surgically, a lot of surgeons want to maintain a minimally invasive approach with these surgeries. Somewhat contradictory because obviously you would like to have less soft tissue disruption. On the other hand, it's more important to implant these components correctly. So if you're malaligned, these implants are going to fail rather quickly. Specifically with regards to the tibia, it has to be perpendicular to the coronal axis and then in line with the native slope on the sagittal view. Varus positioning in these implants, as I mentioned before, very not well tolerated at all. It will result in early failure and loosening. And things like overhang, as you can see here with the tibia, will also result in persistent pain and loosening. Last point here, technically, when performing these or when implanting these components, if you overstuff or make that compartment too tight, it can translate those forces to the contralateral compartment, resulting in early wear and a progression of arthritis. So it's something to be cognizant of. So in summary, I think partial knee arthroplasty is a fantastic operation. There's definitely improved recovery, improved proprioception, a more natural feel relative to a total knee, mainly because you're preserving that ACL. It's definitely bone preserving. So for the young patient, although there's a higher risk for failure, there's also the benefit of preserving bone. The early failure is very real. It's dependent on age, activity level, surgeon's preference, the size of the patient, and then of course, patient selection. And as we discussed, be cautious with the young, obese, and active. ACL tears, contraindication, patellofemoral arthritis, for the most part, contraindication. Thank you. Look forward to answering any questions you have.